Hello, my name is Ruben Mesa, and I'm the Executive Director of the Mesa Cancer Center at UT Health San Antonio, MD Anderson. And I'm excited to participate in this second day of the virtual MPN Horizons meeting, speaking on complementary therapy for myeloproliferative neoplasms. Now, as we try to think about complementary therapies, we first begin with an understanding of what is the burden of having an MPN. Now, many of you that are participating may either directly have an MPN, know someone that has an MPN as you become involved with advocacy in your country or in your region for these diseases. And everyone's journey with an MPN really can be quite different. There are risks of vascular events, the potential of low blood counts and how that impacts on how someone feels and medical risks that it brings to them. There can be the burden of an enlarged spleen. There can be the difficulty of symptoms related with these diseases. There can be risk of progression. And there is, of course, the rest of the individual. We're never just one disease, so there can be the impact of your baseline health, comorbidities, etc. Now, our group has been very interested in studying the symptoms as part of having an MPN to understand what symptoms are there, how do they improve or worsen with therapy, what do they tell us about the biology of the disease. So we, working with many colleagues, have developed a series of questionnaires based on symptoms of mood and vascular symptoms, constitutional symptoms, spleen-related symptoms, fatigue, and quality of life to develop questionnaires such as the MPN Symptom Assessment Form that now have become available in multiple languages, and we've tested them in many different countries. What we've learned is that these symptoms are very common, and in some patients they can be severe. Fatigue is by far the most common symptom across PV, ET, and MF. Difficulties with insomnia are common. Issues of sad mood. Concentration difficulties, particularly with low blood counts or high blood counts. Early satiety or filling up early with an enlarged spleen. Inactivity due to the fatigue. Issues of intimacy or sexuality. Night sweats. Dizziness, abdominal discomfort, bone pain, headaches, abdominal pain, cough, weight loss. And the most rare are fevers. Now, individuals rarely have all of these. Everyone can have their own profile of symptoms that can wax and wane over time. Now, these methods for using questionnaires to assess symptoms both at diagnosis, at the baseline of a treatment, and throughout treatment, have become the standard across many of the clinical trials that have been conducted in MPNs. Now, these symptoms tell us about the biology of the disease. Indeed, over time, there can be issues that increase symptoms, such as inflammation or vascular events. Medicines can help to improve symptoms, particularly JAK inhibitors, but others can as well, even hydroxyurea. Iron deficiency medication side effects can worsen symptoms. So you get a sense that there are things that might improve symptoms and things that might worsen them. So tracking them over time and aiming for the disease to have as little impact on you as possible is part of the goal. People have asked, well, do MPN patients really have symptoms worse than the general public? And working with colleagues in the United Kingdom, we were able to show just that when you look at individual symptoms compared to the general population, there is no question that MPN patients have worse fatigue and other symptoms than the general population. We also saw that symptoms are very consistent across cultures and countries, with scores being very similar between the UK and the USA in patients. Now, these symptoms are not just random. They tell us about the biology of the disease. people have wondered, well, are the symptoms really in people's head? Are they psychological? And the answer is that there can be a contribution of both, but they are mainly driven by biology, inflammation, cytokines, enlargement of the spleen. It is true that uncertainty, mood disorders that can arise from uncertainty, depression, can worsen symptoms. So they both can have a factor. Now, inflammation clearly can have an impact on these diseases, leading to difficulties with nutrition. Inflammation can suppress blood counts, can lead to blood clots and organ dysfunction. Now, as we look at the biology behind these, symptoms like fatigue have multiple ties to the function of the adrenal glands, to our hormonal axis, to low blood counts, and even depression. And we could tie these to changes in inflammatory markers or cytokines in the bloodstream. So there is biology behind the symptom origin. The abdominal symptoms have many links, including prior blood clots, enlargement of the spleen, even nerve direct stimulation, again with many ties to cytokines and inflammation. The, quote, constitutional symptoms of fevers, chills, night sweats can again have many ties to these difficulties, as well as weight loss. And there are many different inflammatory pathways and cytokines implied for these diseases. Finally, there are microvascular symptoms that, again, are driven by the changes in blood counts, impact on a variety of different medical pathways, and subsequent biological links. So before we talk about the complementary therapies and what we know, we have to understand a bit what is our gap regarding our current medical therapies. Complementary therapies should integrate with medical therapies, where both have a role, or what we call integrative medicine, where we take the best of what has been viewed as traditional medicines, pharmacologic agents given to an individual for a disease, and complemented with additional interventions. Now, we know that there's a strong desire by patients to improve the number of options they have for treating their MPN, improving their quality of life, and delaying progression of the disease. Now, whenever we start any treatment, whether it be complementary or a traditional medical therapy, we have to be mindful, what is our goal? Is it avoiding thrombosis and bleeding, improving symptoms, increasing activity, decreasing progression? Our goals are important as we assess the effectiveness of a treatment. We also have to be mindful of time. The time course of an MPN shows us that things evolve over time. Blood counts, which tend to be high at the beginning of the disease, do tend to decrease over time. Symptoms tend to evolve in their profile. The disease do tend to progress over time, particularly after the first 10 years. And the risk of vascular events similarly can evolve. Now, our treatment guidelines are ways that we as a medical field help to establish what is the main path of therapy. And within that path or that road, what are the medical options that we might choose? These are the guardrails. Now, in there might be several that your physician, along with your input, may be able to come up with your treatment plan. Now, in ET, we know that patients, we diagnose, we assess survival, we develop a treatment plan. We've got our frontline medical management, and then we have our backup therapies. And there remain important goals in terms of optimal frontline treatment. Is that hydrea or interferon, or even an acrolide? How do we prevent disease progression? What's the role of JAK inhibition? For PV, the questions are similar. Is that optimal frontline therapy interferon? Many think that it might be. Is it hydrea? How do we prevent disease progression? How early should we consider JAK inhibition? For myelofibrosis, the question's a little different. Should we progress to stem cell transplant? Frontline medical therapy with JAK inhibition, and now multiple therapies that are potential second-line therapies. We know that there is now JAK inhibitor failure, both with ruxolitinib and now we have fedratinib. What does it mean to fail a JAK inhibitor? And what should be the second-line options? We have now 2 approved JAK inhibitors, ruxolitinib and fedratinib, with agents advanced in their testing, pacritinib and momelotinib, that are in advanced phase 3 trials that we hope will become options for patients soon. And there are many agents that are in development, either with or without a JAK inhibitor, as second-line approaches for myelofibrosis. Now, I raise all of these because the medical therapy is, again, the anchor, and the complementary therapies are how do we add other therapies on top to help to improve the status or the quality of life for patients. Indeed, in this second-line therapy, again, we see that many are having activity in the second-line setting in both current trials and future trials, but we still have a ways to go. Indeed, as we look at improvement in these new therapies, and you look at the new options for improvement in green, fibrosis, molecular impact, progression-free survival, overall survival, we still have a ways to go. So how do we weave in complementary or non-pharmacologic therapies? Well, first, there are multiple things that an individual can potentially do that might improve how they feel, might further impact the MPN. Because the rest of your health is important in terms of how you feel, your activity, nutrition, cognition. So our group has been very involved trying to understand these difficulties. And one of my colleagues, Dr. Christina Gowan, and I and others did a large survey of MPN patients, almost 1,000 patients, looking at complementary therapies they were utilizing: massage, yoga, nutrition, acupuncture, meditation, chiropractic. And what you see is that there was a fairly significant utilization, between 30 to 40% of individuals utilizing these various techniques. Now, we have more limited data to understand a comparison between them. Are we at a point where we can recommend one is more effective than another? That we cannot. But we can say that there are many individuals with each of these that have felt significant potential benefits that they have received. Now, in a complementary survey that we did through the Landmark study, we see that probably the most significant therapy used is exercise. And again, would heavily encourage people to be using aerobic exercise to help to improve how they feel. It improves cytokines, it improves inflammation. There are many utilizing supplements. Supplements are quite varied. At this point, we don't have one supplement that we can directly recommend, but there are many that are under consideration, including those such as N-acetylcysteine with Angela Fleischman as an anti-inflammatory supplement. Our group has been very involved in understanding yoga, and now there's many ways to participate in yoga. We had an online version developed for MPN patients specifically and showed improvements in 2 different studies in depression, as well as people's improvements in anxiety, depression, sleep, and fatigue. Indeed, one of the key reasons why yoga, which was done safely and effectively, is helpful in patients is that it improves sleep. My colleague Leslie Paternos from Mayo Clinic has been leading a study on cognition, a MyAct study that is a module developed with psychologists for helping to improve dealing with a chronic illness, and that is an ongoing study. My colleague Jen Huberty and I have been leading a variety of efforts and trials. Some of you may have participated in meditation with the app Calm that has shown improvements in emotional distress, sleep, fatigue, quality of life, and improvements in MPN scores. Calm is commercially available through the iTunes store. We're learning more about it. It is certainly very safe to use meditation, and many have found significant benefit. And nutrition. There's not a patient that doesn't ask, is there something different I should do in terms of nutrition? There are many patients that have found an impact of a variety of different dietary interventions, and that has helped them, going gluten-free, the keto diet. I don't think we can recommend one specific intervention at this moment, but I can share with you that many of these have been helpful for patients, and that they are things you can discuss with your doctor and a nutritionist. Any probably structured diet, to be honest, probably is helpful in terms of decreasing inflammation, control of carbohydrates, helping with overall health, and combined with exercise. Good diet, good exercise can have a significant impact on improving how you feel, almost irrespective of your medical situation. And now we have ongoing trials which are planned, Calm for sleep in both cancer and MPN patients, to try to directly impact sleep, which can be one of the most important. And then we now have a grant from the National Cancer Institute trying to develop meditation as a better intervention, as a complementary therapy for both MPN and cancer patients. So I'll leave you with these conclusions. For MPNs, we need to understand the full burden that a patient has and develop appropriate therapies and goals. If those therapies are not beneficial, we need to consider an alternative approach and complementary ways. I view that these complementary therapies should be layered in addition to our optimal medical therapy. It really should not be a question of either or. It's not a question of meditation versus a JAK inhibitor. It's a question of you get the best situation you can with medical therapy, and then you try to use nutrition, diet, yoga, exercise, other things to further improve your health, improve your quality of life, to better manage symptoms. I think we'll learn more about supplements and non-pharmacologic supplements over time to perhaps further augment these capabilities. And with that, I'll conclude, but very much want to thank our MPN Quality of Life Study Group, with many wonderful friends and colleagues from multiple institutions contributing to these efforts. Thank you.